Very good morning to all of you, and I thank the organizers for their kind invitation to me. So, both PRP and hyaluronic acid are only symptomatically giving some relief. They are not curative. So, what we are looking for, some form of treatment is a curative treatment which will help patients in the long run. So, I have no disclosures to make. Before we go on to the stem cell therapy, let's look at the structure of the cartilage. Now, cartilage, when I talk of articular cartilage, is typically hyaline, and it is constituent of chondrocytes, type 2 collagen, proteoglycans, and water. Water constitutes around 70% of a hyaline cartilage, whereas extracellular matrix, which is called as glycosaminoglycans or aggregans, constitute about 20% of the volume of the cartilage. Chondrocytes are hardly 1 to 2%. Now, there are few peculiarities about the chondrocytes or the cartilage. Cartilage lacks direct nerve supply or any vascular supply or any lymphatic drainage. So, they don't have access of the progenitors to reach the cartilage in case of there is some injury or some repair is needed. Their metabolic activity is very low, and the proliferation of chondrocytes is very, very slow. The reason being, the cartilage, I will show you the structure in the next slide, and I will explain there. So, if you see the cartilage, it is made up of 4 zones. The superficial tangential zone, which is comprised of flattened chondrocytes and parallelly arranged thick bundle of collagen 2 and collagen 9. Below that is the area which is called as middle zone, which constitutes around 40 to 60% of the cartilage structure. And here the collagen bundles are arranged in the slanted or the radial distribution, and they have got lot of glycosaminoglycans. Now, what is the significance of these glycosaminoglycans? They are hydrated. They trap the water inside them and makes the cartilage very spongy, so that it can withstand absorb the vibrations or the shear stress. Below that is the deep zone, which constitutes around 40% of the cartilage structure, and here the collagen bundle is arranged in the parallel bundles in perpendicular to the joint surface, and the chondrocytes are arranged parallel to these collagen bundles. This provides a greater resistance to the shear stress, and below that is the deep zone or the calcified zone, which constitutes around 5 to 10%, but which has got the greatest ability to withstand the shear stress. Now, if you realize from top to bottom, the hypoxic environment is increasing. So, the chondrocytes, they reside in a very peculiar environment, and they have to withstand this hypoxia. That is why their metabolic activity is very low, and that is why it's very difficult to heal, because they cannot proliferate rapidly once the regeneration is required. So, what are the causes of the osteoarthritis? We all know that aging is the important cause, obesity, some trauma, or there is some kind of a abnormal metabolic loading, and also genetics play an important role in the osteoarthritis generation. What all it does lead to? It leads to breakdown of the extracellular matrix proteins. When I say this word, I mean to say that the glycosaminoglycans are lost, the collagen 2 is lost, and there is a senescence phenotype of the chondrocyte. By this I mean to say the chondrocyte become hypertrophic, they cannot proliferate, and they cannot have a synthesis of glycosaminoglycans. So, this leads to sort of factors which predispose to osteoarthritis, like by releasing of matrix degrading enzymes. The important one is matrix metalloproteinase 13. Also, it leads to exaggerated immune response by activating synovial macrophages, and by introducing the synovial macrophages into the joint compartment, it leads to release of various pro-inflammatory cytokines like interleukin 1 beta, tumor necrosis factor alpha, and interleukin 6. Now, these are the 3 important cytokines which leads to cartilage degradation, because they induce apoptosis of the chondrocytes. So, what can stem cell do? So, unless there is a regenerative potential to treat the cartilage, we cannot have some form of cure. Stem cells are the precursor cells which have a property to renew themselves and also to differentiate into the other cell lineages. They can come from different sources, from embryonic sources as well as from the adult afterbirth sources, which are generally termed as mesenchymal stem cells. Embryonic stem cells have their own problems of causing tumor, or risk of tumor is very high. So they are, and plus ethical issues are there, so they are not in much use. But mesenchymal stem cells derived from various sources are being tried out in treatment of osteoarthritis. So these mesenchymal stem cells can differentiate into various lineages, including bone, cartilage, muscle, tendon, or other connective tissues. Now, what are the mechanisms of these mesenchymal stem cells by which they can have some form of response? So earlier it was believed that they can have a regenerative potential, so they will replace the lost cartilage, but that is not good enough. They have got, in addition, other mechanisms, whereby they have anti-apoptotic mechanism, so that whatever chondrocytes are there, they survive. It leads to more of angiogenesis, so that precursor progenitors, which are in the nearby vicinity, they can also go on to invade the cartilage and can provide some form of a cell support and can regenerate into the chondrocytes. Also, they have got a very important property of immunomodulation. Now, how does it lead to immunomodulation? It affects almost all the cells of innate and the adaptive immune system, so that immune response goes down. And not only that, it also leads to an environment where it allows the proliferation of the surviving chondrocytes and differentiation of the progenitor cells into the chondrocytes. So let's look at some of the evidences which are available. Coming to the preclinical models, this is a data which has been taken from one of the articles, where 23 articles were actually evaluated for evidences to support in animal whether mesenchymal stem cell therapy has got some relief or not. So they have used different models of osteoarthritis, like monoiodoacetate injection model, or tear of the, or transection of the anterior cruciate ligament. And they could demonstrate that both allogenic bone marrow as well as autologous synovial mesenchymal stem cells have got some potential and some mechanism by which they cause betterment of the animal osteoarthritis. So this is a data of 23 studies, and the conclusion of this study was that preclinical studies have got sort of highlight the importance of therapeutic potential of mesenchymal stem cells in the treatment of OA in animals. Another meta-analysis of 53 studies in animal has also shown that not only clinical but microscopic and histological evidences are there to suggest that when you treat these animals with mesenchymal stem cells, they have got better responses as far as osteoarthritic model is concerned. And the risk of bias in most of these studies was very low. So this is a very important, good evidence to suggest, yes, we should use or try out mesenchymal stem cell therapy in humans for osteoarthritis. Now let's look at the data on mesenchymal stem cell therapy in humans. So this is how you take whatever source you can see, either bone marrow, adipose tissue, synovium, umbilical cord, or placenta, and you grow these mesenchymal stem cells in the culture lab, authenticate or characterize these mesenchymal stem cells, and then go on to inject into the knee joint of the humans. Also, there is another strategy which has been used to induce pluripotent stem cell. If people are aware of Yamanaka, who discovered 4 transcription factors which actually induces an adult human fibroblast to convert into an induced pluripotent stem cell, then these cells can also be differentiated into mesenchymal stem cells and can be injected. There are studies for that also. The very limited data is available. So I'll just briefly introduce to a study which we have also participated. Our center has also participated. This was a phase 2 dose finding study and safety study to see whether pooled allogenic mesenchymal stem cells can have some response in osteoarthritis or not. So they have given data for both preclinical as well as clinical data. In the preclinical study, they have shown, if you look at the diagram in the C picture, they have prepared 6 batches of pooled mesenchymal stem cells, and they could demonstrate that they all have got a very good differentiation towards glycosaminoglycan secreting mesenchymal stem cells. And not only when they used it in the animal model, where the model was monoiodoacetate injection, it could demonstrate that the reduction in the pain was much significant in animals who had received these mesenchymal stem cells. also given by the histological evidences in the picture below. They stain these cartilages with safranin O. Now, what is safranin O stain? It stains the glycosaminoglycans. For a hyaline cartilage, you need a good amount of glycosaminoglycans, and the red staining can be seen in favor of glycosaminoglycans. So, in animals who had received stempucell and hyaluronic acid, they have got a good amount of glycosaminoglycan staining. So, there is a definite preclinical evidence to suggest efficacy of their mesenchymal stem cells, which they have named as stempucell. Then they go on to investigate their product in 4 different doses, 25 million, 50 million, 75 million, and 150 million in 60 patients across India. And they could demonstrate, yes, in the dose of 25 million mesenchymal stem cells, the efficacy was there in reduction of visual analog scale pain as well as WOMAC scores, though they were not significant as compared to the placebo that they have also mentioned in their final conclusion. But this gives them an idea, yes, that molecule is safe, and rather than going for a very high dose of mesenchymal stem cell, they could have treated or has gone ahead with a low dose, that is 25 million dose of mesenchymal stem cell. Then this group went on to investigate further with the phase 3 study, where 146 patients were randomized, 73 to placebo arm and 73 to the mesenchymal stem cell, and the dose they have used now was 25 million. And they could demonstrate that, yes, WOMAC score at the end of 24 months was significantly low in patients who had received mesenchymal stem cell at a dose of 25 million. And similarly, there was a marked reduction in WOMAC change in the pain, stiffness, and the physical function. Not only this, they have done a MRI-based T2 mapping for cartilage quality, and they could demonstrate, yes, the cartilage is showing increase in both superficial cartilage as well as deep cartilage volume. Now you can correlate the structure what I have shown in the beginning, that it is also causing good quality cartilage formation. So let's look at some of the evidences which are there in multiple studies across the literature. This meta-analysis has evaluated the efficacy of 23 studies, and they again came to a conclusion, yes, mesenchymal stem cells from various sources, including bone marrow, umbilical cord, and blood, and including adipose tissue, has got some efficacy in treatment of knee osteoarthritis. Another study which has actually evaluated 28 studies or 28 RCTs, they also came to a conclusion that WOMAC pain overall, WOMAC visual analog scale, as well as WOMAC stiffness and physical function, they all showed a good improvement in patients who had received mesenchymal stem cells from different sources. In this particular meta-analysis, what they have been able to compile was that patients who had received adipose-derived mesenchymal stem cells, they had a good response. So that is what they actually concluded. The adverse events were similar between mesenchymal stem cell treated or placebo treated arm in multiple studies. So they concluded that mesenchymal stem cells have a good curative effect in treatment of osteoarthritis, and this effect starts as early as 3 months and is maintained till 12 months. Adipose-derived mesenchymal stem cells have a better efficacy according to this meta-analysis. And here I have shown another meta-analysis which has shown that as the time increases, the efficacy of adipose-derived mesenchymal stem cells tends to improve with time. We can see the improvement was less at 1 month, but kept on increasing till the end of 24 months. So this was the conclusion of the study, that adipose-derived mesenchymal stem cell have got some role to play in osteoarthritis. So what are the challenges as of today? So I listed a lot of causes, including the standardization of the procedure for isolating, cultivating, and characterization of stem cells, to know the exact time and type of mesenchymal stem cells to be given a particular patient. Also, people have tried autologous versus allogenic. Autologous doesn't have much of efficacy according to most of the studies, whereas allogenic has a good effect. And similarly, there are other comorbidities issues to be resolved, whether patient with high BMI and comorbidities needs to be given what kind of stem cells. Also, the outcome measures need to be standardized across the studies. So what are the way forward? So the way forward seems to be that if you can have some kind of a platform where you can give mesenchymal stem cell based on some delivery mechanism where the mesenchymal stem cells stays for a longer period of time into the joint, and also they have more of a chondrogenic differentiation, then they can have a better efficacy and long-term effects can be seen. So hydrogels which are combining various growth factors or various small molecules like cartoginin or resveratrol are now actually in animal usage and are showing a good effect. So probably in coming time that we will have mesenchymal stem cell therapy along with hydrogels based on some small molecules or growth factors can be the sort of way forward to look for patients for osteoarthritis. With this, I would like to thank you for your patient listening.